Welcome to Session 4 of the 18th National Health Research Forum for Action. Session 4's title is Optimizing Financial Resources for Universal Healthcare in Times of Pandemic. Our moderator and facilitator for today is Mr. Virgil Declaro. Good morning, Mr. Declaro. Department of Health, DOH, Department of Science and Technology, Philippine Council for Health Research and Development, DOST PCHRD, and the Ateneo de Manila University Institute of Philippine Culture, or ADMO-IPC, are providing this webinar as a public service, but it is neither a legal interpretation nor a statement of DOH, DOST PCHRD, or ADMO-IPC policy. Reference to any specific product or entity does not constitute an endorsement or recommendation by the DOH, DOST PCHRD, or ADMO-IPC. The views expressed by speakers, facilitators, and viewers are their own, and their appearance on the program does not imply an endorsement of them or any entity they represent. Views and opinions expressed by DOH, DOST PCHRD, or ADMO-IPC employees are those of the employees and do not necessarily reflect the view of the DOH, DOST PCHRD, and ADMO-IPC or any of its officials. Again, ladies and gentlemen, Mr. Virgil Declaro.
Hi, good morning, everyone. We would like to welcome you to the 18th National Health Research Forum for Action. We are now down to our fourth session titled Optimizing Financial Resources for UHC in Times of Pandemic. First of all, I would like to read through the webinar rules. If you encounter connection problems during the webinar, please click the reconnect button found at the top of your screen. Please use also the chat box on the right side of your screen for questions and comments related to the webinar at any point in time. Your questions will be read right after the presentation. Please state your name and affiliation with doing so. And finally, we value respect and courtesy the most, so all throughout the webinar session. All right, so I am Virgil Declaro, and I will be today's discussion facilitator. To formally start the program, we'll have a short prayer.
Let us put ourselves in the holy presence of God. Father in heaven, always merciful and giver of life, we humbly ask that you bless each one of us, from the speakers, program committees, guests, and participants. Guide us to make better decisions as we incorporate what we will learn throughout this activity. Thank you for the infinite blessings and countless opportunities. Lord, today as we start our activity, may we always be grateful to learn new things. Shed the light of your wisdom and bless each one, especially our speakers, as they will share their knowledge to us. Through your mercy and grace, may peace and utmost understanding shine and dwell unto us. Almighty God, accompany each one and help us concentrate for us to gain more knowledge as we listen attentively. This we ask in your name. Amen.
So once again, good morning and welcome to the fourth session of our National Health Research Forum for Action. We would like to welcome all of our attendees, our distinguished speakers and reactors for this morning. But before we proceed to the presentation proper, let's have a short recap of our previous sessions. In the first session titled Transparent Governance and Accountability in the Face of COVID-19, this happened last September 8th. The session showcased the governance indicators used to measure health sector performance and the studies behind the public health measures employed by Department of Health in addressing COVID-19, which manifests the transparency and evidence-based interventions anchored on universal health care principles. The next day, that was September, the second session titled Strengthening the Local Health System featured the integration of local health systems into province-wide and citywide health systems, studies on local government units such as the UHC Primary Care Study, the e-health study, and social innovations in health systems were presented. The third session, titled Ensuring Continuity of Health Service Delivery Amidst the Public Health Emergencies, was split into two parts, which were then held last October 6 and 7 respectively. The first part focused on human resource for health in health facilities, where we featured studies looking into optimization and utilization of COVID-19 health facilities and assessment tool used for health facilities. The second part, on the other hand, focused on special populations. This tackled primarily health service delivery for Filipino migrants and overseas workers, as well as local children and elderly population. It showed areas of vulnerabilities and offered recommendations of these populations, especially in this time of the pandemic. And for this session, the fourth session, we hope you'd learned something new in today's discussion. We all know that COVID-19 has affected much, not only a number of people in the country, but the way we actually do things. In fact, it has also affected our economy. And rightly so, it would be very interesting for us to look into how COVID-19 has potentially affected the country's revenue generation and health spending, and how it impacts on the planned implementation of UHC. So for the first part of the program, we are joined by Director Francis Rose Ilgumamaril to present updates on the presentation and fund sources of the UHC budget in the context of COVID-19 pandemic. Director Ilgumamaril is currently the OIC Director 4 of Department of Health, Health Policy Development and Planning Bureau, and managed the development of the National Objectives for Health 2017 to 2022. Director Francis is also the co-lead secretariat in the UHC Implementing Rules and Regulation Technical Working Group for Financing, and she is a Hubert H. Humphrey Fellow. Ladies and gentlemen, let's all welcome Director Francis Ilgumamaril. Good morning, Director Francis.
Good morning, Mr. DeClaro. Good morning, everyone. I'm going to present to you the budget for universal healthcare. I outlined my presentation as follows. So first, I'm going to present to you the F1 Plus for Health strategy map. Next slide, please. Next is updates on UHC implementation, fund sources for UHC and DOH budget trend, UHC funds in the DOH and Philhealth budget, funding of projects, activities, and programs related to UHC Act implementation, resource gap for universal healthcare, and allocation for UHC integration sites in 2021. Let me start with the Department of Health's vision for the Filipinos, which is to be among the healthiest people in Southeast Asia by 2022 and in Asia by 2040, by leading the country in the development of a productive, resilient, equitable, and people-centered health system. The DOH is guided by the core values of professionalism, responsiveness, integrity, compassion, and excellence to achieve better health outcomes, more responsive health system, and equitable healthcare financing. The F1 Plus for Health, which is the strategic framework for the health sector, has 5 pillars, namely financing, service delivery, regulation, governance, and performance accountability. The F1 Plus for Health is sort of institutionalized through the enactment of the UHC law. The next slide will show you what universal healthcare means. UHC means all Filipinos are able to access quality and affordable health services they need without exposing them to financial hardship. This means no Filipinos should be left behind. Every Filipino should be able to access and receive effective health care without worrying about how they're going to pay for the health services they receive. Now let me give you updates on the UHC implementation. Republic Act 11223 or the UHC Act was signed last February 2019, and the development of its implementing rules and regulations were immediately initiated by the Department of Health. As the UHC Act is a complicated law, the IRR development process underwent a series of workshops, roundtable discussions, and nationwide consultations from March to October 2019. After the approval of the final draft by the Executive Committee of the Department of Health and Philhealth Board, the UHC Act IRR was finally signed last October 10, 2019. Next, before we proceed to the budget for universal healthcare, may I provide you some updates on the implementation of the law. First, we were able to issue implementing guidelines for the following areas: mechanisms for local health system integration, standards for the delivery and financing of health services, strengthening local planning for health, and monitoring and performance assessment of the LGUs. Second, we initiated the first phase of the UHC implementation by gaining support from the initial 58 UHC integration sites, composed of 9 HUC, ICC, and 49 provinces. Third, we prepared and updated staffing proposals based on the requirements of Universal Healthcare Act. And lastly, we allocated budget for the technical assistance to the UHC integration sites for FY 2021. Next, our 2021 budget proposal is actually the transition year before the full implementation of the Mandanas ruling through the LGU revenue allotment in 2022. A total of 351 billion is needed by the DOH and Philhealth to fully implement universal healthcare under a high-cost scenario. In the next 3 years, a total of 1 trillion budget is needed by the DOH and Philhealth. On an average, the annual UHC funding requirement is around 357 billion, based on the 3-year average of the medium-term expenditure plan from 2021 to 2023. The reduction in the total cost in 2022, as you can see in the slide, is due to the front-loading of investments in 2020 and 2021, particularly those that are related to Kovid or health system resilience. Based on the high cost estimate requirement in 2020 and 2021 for UHC, as compared to the General Appropriation Act, or in terms of 2021 NEP level, we have a resource gap of 66 billion pesos for 2020 and 148 billion for 2021. A large part of the resource gap is for Philhealth premium subsidies, followed by HPEP, public health commodities, operations of DOH hospitals, blood centers, treatment and rehab centers, and the national and subnational reference laboratories. Although there is still a budgetary gap, please take note that the DOH budget has increased significantly with the syntax law since 2014. The 2021 budget in the National Expenditure Program is 27% higher than the 2020 budget level. The next slide will show you that the budget for health is sourced out from the syntax incremental revenue earmark for health, represented by the yellow shade in the graph, compared to the baseline budget of the DOH OSEC and Philhealth in 2013, represented by the blue shade, which amounts to 53 billion. The syntax incremental revenues for health has provided significant contribution in the budgetary support for the DOH and Philhealth, increasing it by 3-folds. Aside from syntax, as stated in Section 37 of the UHC Act, there are other sources of appropriations to fund the implementation of, namely, first syntax. Aside from that, we also get from PAGCOR, PCSO, premium contribution of members, annual appropriations of the DOH included in the GAA or General Appropriations Act, and national government subsidy to Philhealth included in the General Appropriations Act. Given those sources of fund for universal healthcare, an estimate of 209 billion is the total funding for UHC in 2021. Please take note that this is tentative pending the clarifications from the Bureau of Customs and the DBM. So 53 billion is from DOH OSEC and Philhealth baseline budget since 2013. 101 billion is from the 2019 sin tax collections from incremental revenues for health, minus the LGU share. 43 billion is from DOH and Philhealth natural increase. PAGCOR is 7 billion and PCSO is 3.7 billion with a total of 209 billion. The next slide will show you that in summary, a total of 98.62 billion out of 171 billion or 57% of the DOH OSEC and Philhealth budget is allocated for the implementation of Universal Care Act in 2020. On the other hand, a total of 110 billion or 56% of the total budget of the DOH and Philhealth in 2021 is allocated for UHC. Under the DOH OSEC, a total of 27 billion is funded for the provisions of the UHC Act in the 2020 GAA, and a total of 38 billion is allotted assistance for the local health systems integration, implementation of health technology assessment, commissioning of researches related to UHC, deployment and capacity building of human resources for health, enhancement of the DOH capacity to license primary care facilities, and health information technology. Meanwhile, the population-based health services include the epidemiology and surveillance, and health emergency preparedness and response, and health promotion. Lastly, the programs and projects related to primary care service provisions are public health programs, management, and commodities for immunization, family health, nutrition, TB control, prevention control of infectious diseases, elimination of endemic diseases, rabies control are the budgets for PPE and COVID vaccine. For 2020, total additional amount for COVID response is 66 billion. For 2021, we have a total of 13 billion in 2021 net. We are appealing for additional budget to increase allocation for COVID response. For the UHC integration sites, a total of 11.97 billion is allotted under NEP 2021 to cover the following activities. Deployment of all cadres in the sites amounting to 9.75 billion. Expansion of various local health systems integration sites. I think that is the last slide of my presentation. Thank you very much for your attention.
Thank you very much, Director Ilguma Maril, for your presentation. We will have you in a little while, during the Q&A segment. Our participants, if you have any questions related to any of the presentations that were given, kindly send them to our chat box. So to proceed, let's call on now the Acting Chief Operating Officer of Philhealth, Ms. Nerissa Santiago, to present to us the broad strokes and actions undertaken by Philhealth during this COVID-19 pandemic. COO Santiago, I'm turning the floor over to you.
Good morning, Mr. Jaker. Good morning to everybody. Okay, I will be presenting a situation on the Philippine Health Insurance Corporation regarding our UHC implementation and as well as the COVID response to this pandemic. Okay, as you can see from the slide in front of you, this is our corporate strategy map in response to the UHC. I think Ms. Francis already stated earlier that the goal of the country is to have the Filipinos among the healthiest in Southeast Asia by 2022 and Asia by 2040. For the goal of Philhealth to contribute to this goal is to have satisfied clients by having um, the total client experience and responsive benefits for its members, and as well as sustainable funds, while generating revenue and optimizing assets through investments. To achieve these goals, our excellent the excellent processes that we need to put in place is to strengthen stakeholder relations, ensure operational effectiveness and efficiency, and boost innovation in research and for policy and processes. And to support these processes as well as goals, we need to have strong foundation in terms of creating transformative leadership and culture, ensure organizational alignment and workforce engagement, and with this, the integrated and optimized information systems. Next slide. Okay. So the way forward, Health is when we developed the Philippine Strategic Plan, it is one of the three interlocking initiatives that is envisioned to transform Philhealth into an organization that aggressively takes on the mandates under the UHC while being aware of the path to take in the new normal. These three initiatives can be taken as unique angles that is necessary for Philhealth to make a leap forward. So we start with Philhealth Omnibus Rules, which provides the policy perspective, ensuring that the corporation is guided in its policy decisions. And of course, the business continuity plan provides the predictive perspective that anticipates how Philhealth will have to operate in a disruptive environment. And within this three-pronged interlocking initiatives, the Philhealth strategic plan ensures that a sustained vision for the future is being pursued, giving it a transformative perspective. Next slide. Okay, so for this, the Philhealth strategic plan is composed of two stages, wherein we envision Philhealth 2.0 focusing on enabling strategies. This will transition the current information systems, which are currently on a legacy system, specifically on collection, and to transform also competencies towards Philhealth 3.0. The core strategy will be limited to collection mechanisms and especially the consulta implementation. This will be the transition plan from the current to Philhealth 3.0, wherein the focus on core strategies will be the implementation of the comprehensive primary care benefit, the global budget-based systems, and of course the cost containment policies which will encompass the fixed co-payment as well as co-insurance. For the enabling strategies under the Philhealth 3.0, this will include implementation of digital-based processes and information systems and a new organizational structure that will be responsive to the UHC implementation. Okay. So this is slated on starting 2024 until 2028. We envision the Philhealth 3.0 to be in place. As a continuity, we want to have a long-term thinking strategy implementation which covers at the minimum these two medium-term plan. With the collaboration, we identify collaborative dependencies with other agencies, especially Department of Health and the Philippine Statistics Authority, for specific strategies to move forward. And for the sustainability, we integrate contingency planning in anticipation of possible large-scale shocks and risks, which is evident by the current pandemic. Okay. The Philhealth Strategy Map 2021 to 2023 is focused on three outcomes, specifically increased utilization based on need, higher financial risk protection, and quality healthcare services. This can be achieved by the um, reduced out-of-pocket, improved health outcomes of patients, as well as increase in utilization for primary care benefits. For the sustainable financing, we want to build a deep revenue base, um, efficient and with efficient collection system for to maintain an active risk pool through strategic purchasing. So this will enable us to have a sustainable financing. And for the innovation and growth, that will cover both systems and the organizational structure. We want to have to enhance the information system through enterprise integration, design an agile and adaptive organization, transform the human resource management with the competency-based approach, and develop lean and member-centric processes. So this will help us in the achievement of the outcomes that we want to for this PhilHealth strategy map. Okay, next slide. Okay. So in response to the current pandemic, we have implemented the inpatient treatment packages for COVID-19. This comprises of the mild pneumonia, moderate pneumonia, severe and critical pneumonia, with the as specified in the package rates. This is stated in the PhilHealth Circular number 2020-009, wherein specific to this circular is no co-payment for direct healthcare services for both public and private healthcare institutions, as well as continuous. We are now conducting continuous updating of packages based on additional costs data from HCI. So we are currently reviewing these COVID packages, and we will be coming up with a revised package rates soon. Next slide. For the testing treatment packages for COVID-19, we have three packages for this COVID-19 testing package. This is stated also in the PhilHealth Circular 2020-0017. Again, there is no co-payment for testing services, and the laboratories should be certified by RITM. These testing packages and the coverage of PhilHealth should be in accordance with the DOH guidelines in terms of who will be covered and will follow their protocol. For the community isolation package for COVID-19, a package rate of 22,000. This is provided by accredited and DOH certified community isolation units, temporary treatment and monitoring facilities. This package includes a minimum 14 days admission, inclusive of boarding, food, and individual hygiene kit. Information and education about respiratory etiquette and self-monitoring, and monitoring by a healthcare professional. So other services that can be needed are also covered, like drugs and medicines, diagnostics, and referral and transportation to higher level facility. Other assistance that we have given in response to the COVID pandemic, as you know, already know the controversial interim reimbursement mechanism. This will help the hospitals through this pandemic with their financial resources. We also have the relaxation of specific rules within the Phil Circular 2020-007 during fortuitous events, wherein the 45-day benefit limits, single period of confinement rule, less than 24-hour confinement rule, and that members can file direct claims for COVID-19. These are the special privileges that are within this fortuitous event circular that we are covering. And recently, we already clarified that even the dialysis in excess of the 90 days will also be covered until December 31 of this year. For other support of to healthcare institutions, we also relax some of the rules, for specifically the submission of claims from 60 days to 120 days after discharge, reimbursements for both referring and receiving healthcare institutions, priority in processing of claims for COVID-19 facilities, extension of submission, as I have said earlier, and the extension of the accreditation validity and or submission of application of healthcare providers. For uninterrupted public service, even during the implementation of the ECQ, Philhealth offices remain to be open with essential personnel reporting in. PCares also continue to provide services in healthcare facilities, and we also optimize the use of online platforms such as teleconferencing, social media applications, and 24/7 call center. I think that's my last slide, and thank you so much for listening, and good morning.
Thank you very much, Mom Santiago, for your presentation. May we request now Director Ilguma Maril to join us again as we open the floor for the Q&A segment. All right, so we would like to remind everyone and encourage our participants to key in their questions to any of our presentations, the chat box, and we will try to read them to our presenter this morning. Yeah, so I think we have a very good two presentations that were given this morning, and I think this set the whole discussion, the tone for the entire discussion on optimizing financing for UHC in times of the pandemic. So again, may I request Director Ilguma Maril to join us as we go into the Q&A segment. All right, so okay, so we don't have yet any questions from our participants, but I'd like to follow the presentation earlier with some of my questions in mind now. So as I've mentioned earlier, these two presentations from both the DOH and Fieldhealth actually sets the tone for the overall discussion on what we can actually do in terms of optimizing our financing for UHC. And early on, you have both presented the plans in programs, which I think did not yet cover entirely some of the considerations for COVID-19. And probably for 2021, we won't have that much of a problem in terms of the resources. But as we look at how the entire situation will pan out in the next 2 to 3 years, do you think there is a need for us, or what are the things that we're actually doing right now from both the side of DOH and Fieldhealth in terms of are there any adjustments in the plans, and how we you know, augment the resources needed for implementing UHC in probably in 2022 onwards? Uh,
Thank
who would
you,
like to start?
Shaker, for the question. Yeah, I can start.
Yeah, sure. Director Francis, go ahead.
Um, it's very crucial that we have adequate funding for UHC for this to the UHC Act, like what type of activity should retain with the DOH, given that the mandanas should be implemented fully by 2020. So we're trying to come up with, given that scenario, and aside from that, we are also trying to engage the Congress in terms of providing enough funding for UHC. So we included allocation for the support, no, to the integration sites, the UHC integration sites, and also provided funding for the priority activities in the UHC, specifically the population-based health services, which are also crucial for the COVID response. Unfortunately, based on the NEP, we're having problems in terms of the sufficiency of going, no, the budget, Mr. Jaker.
Yes, go ahead. Director Francis, you are actually, you have, I think you have an intermittent connection. We can't hear some of your responses earlier. But I'd like to ask COO Santiago to provide her response, please.
Hi, Jigger. Just to clarify, the question is, do we have enough budget for UHC implementation? Okay. Currently, we have enough funds to address the benefit payouts for the current year as well as next year. However, because of the pandemic, for which we don't have enough funds for that. The reserve fund is not on the level that we can address a pandemic when it occurs, such as this COVID-19 pandemic. So because of the additional claims that will be coming in because from the COVID inpatient as well as isolation package and testing, although we have enough funds, we might have insufficient funds for the coming years, especially if there will still be a spillover of the pandemic by next year. So we are aside from the increased benefit payouts, there is a decrease in terms of collections because of the downturn in the economy from the retrenched employees. We are having problems, or we have lesser collections despite the increase in the contribution rate as legislated by the law. So that's one of the balancing act that we need to do, and for the legislators to provide us more funding for the following years. Yes.
All right. Yeah. So actually, there is also a question in the chat box, that says that which I think you have already covered in your answer, the effect of anticipated effect when it comes to Fieldhealth on the membership premium collections, and so you have said it has gone down. And do you think there are and as you have mentioned, you have to probably ask government to fill in any of these gaps, no, as a way forward. But other than that, are there any changes that you are going adjustments in terms of the plans in moving forward? Should these resources be not really be made available at the onset?
Aside from the asking more funding from the government, I think there is available funding because of the law coming from the PCSO and PAGCOR, but that is still under discussion with the DOF and DBM. There might be a delay in terms of UHC implementation. So instead of expanding the consulta for all Filipinos by next year, there might be, and especially it is also part of one of the factors would be the access available for the primary care providers. So the implementation of the consulta might be affected. We might be doing some pilot implementation to test the networking in terms of the primary care benefit. But aside from that, because of the immediate eligibility provision in the law, there is the members are still entitled to receive the benefits despite the decrease in the collection. So definitely, the government has to step in terms of funding.
Right, right. That's true. Well, there is a follow-up question here for you, Ma'am Neri. No? In retrospect, what measures should have been done by Philhealth in terms of financing and beyond to prepare better for the pandemic as well as for the recent calamities? No? This is a question from Dana Adrian Marciliana.
In terms of getting, or how do you call it, preparing for this unexpected occurrences, there is a provision, of course, in the law that we can accumulate reserve funds up to the level of 2 years program expenditures. But for us to maintain at least the enough funds or enough capital to address these pandemics and the unexpected occurrences, there is that risk appetite level that the board had set, for which we need to set the reserve fund at the minimum 1 year program expenditures. That means the reserve fund should be enough to cover at least next year's program expenditures, including the operating expense and the benefit payouts. Aside from that, I think what Philhealth has to do should be having this integrated system. This will help us, for one, improve our collection efficiency. If there is the system is integrated, then there will have more elbow room to assess what needs to be collected. Next, and most importantly, is if there is an integrated system, we will be able to detect fraudulent claims, and this will help us lower our benefit payouts. So the planning should be in such a way that we are able to increase the funding, the inflow, as well as decrease the outflow in terms of preventing fraudulent claims. So I think a lot of our reforms is dependent on the integrated systems that we need to put in place.
All right. Yeah. Thank you very much, COO Santiago, for that answer. Now, we would like to inform the attendees that we actually read through your different questions that are hid in the chat box. And many of these questions are related to benefits development. So I would like to part these questions for our presentation that will be given later on benefits development. So I won't be asking this to COO Santiago, as there will be another speaker who will be uh, more appropriate to be able to answer this question during her presentation later on. So I think we have already covered the number of questions that were raised in the chat box on related to these two presentations from DOH and Fieldhealth. So thank you very much, Director Francis Ilgumamaril, and to Field's Acting Chief Operating Officer, Ma'am Marisa Santiago, for your expertise and to our participants for sending in their questions. But if you wish to send more of your questions, please do so to this particular email, nhrfa2020@gmail.com. So you can continue to send in your questions to that email, and we'll be able to we will collect them, no, and send them to our resource speaker. So thank you very much once again to our first two resource speakers this morning. We will have a 5-minute break, and we'll be back for the presentation of additional studies this morning. Thank you.
Patuloy pa rin ang laban natin sa COVID-19. And together, we can beat the solution.
B. Bawal walang mask.
I. Sanitize sa mga kamay. Iwas hawak sa mga bagay.
D. Kumistansya ng 1 metro.
A. Alamin ang totoong impormasyon tungkol sa COVID-19.
Protektahan natin ang sarili at mga mahal sa buhay.
B-I-D-A. Be the solution sa COVID-19.
Hindi pa rin natatapos ang laban natin sa COVID-19. At sa labang ito, isa sa pinakamahalagang armas natin ang tamang impormasyon. Importanteng maalam tayo kung paano ba natin mababawasan ang tsansang mahawaan tayo ng COVID-19. Pero, ano nga ba ang alam natin ngayon tungkol sa pagkalat ng COVID-19? Base sa kasalukuyang pag-aaral, ang COVID-19 ay sumasama sa droplets sa tuwing may umuubo, bumabahing, kumakain, nagsasalita, o kahit sa paghinga. Kadalasan, hindi natin namamalayan ang pagtalsik ng mga droplets na ito dahil hindi sila nakikita. Ano naman ang magagawa natin para maibaba ang exposure natin o tsansang magka-COVID? Kailangan nating maibaba ang exposure mula sa virus tuwing nakikipagsalamuha tayo sa iba. Isa sa pinakamainam na tool ang face mask upang mabawasan ang ating exposure at ang pagkalat ng COVID-19. Kaya naman, face mask ang bida topic natin for today. Binabawasan ng mask ang tsansang makahawa at makapanghawa tayo sa ibang tao. Ayon sa current studies, kaya nitong bawasan ang ating risk of infection ng 67%. Ngayon, napakadami ng face mask na available para sa atin. Ika nga options of
Oo nga eh. Nag-ano ako.
Patuloy pa rin ang laban natin.
Bawal walang mask.
Ngayon, alam na natin na maaari tayong gumamit ng cloth mask. Alalahanin po na hindi pwedeng i-side A at side B ang cloth mask. Labhan ito araw-araw gamit ang maligamgam na tubig, detergent at bleach. Para naman po sa mga medical or surgical mask, tandaan na hindi ito maaaring i-recycle. Itapon na ito pag madumi na, basa na o gamit na. Samantala, ilaan naman po natin ang mga N95 mask para sa ating mga healthcare workers na patuloy na nakikipaglaban sa COVID-19. Huwag din po nating kalimutan na hindi natin nirerekomenda ang paggamit ng N95 respirators with valve. Habang kaya nitong protektahan ka sa virus, hindi naman ito mapoprotektahan ang mga tao sa paligid mo, lalo na kung may sakit ka. Of course, face masks are not enough to protect us. It should still be coupled with other preventive measures. According to studies, kung magsuot ka lang ng mask at didistansya ng at least 1 metrong layo sa iba, mababawasan na agad ang tsansa mong makahawak at mahawaan, kaya ituloy lang natin ang pagprotekta sa ating mga frontliners at komunidad sa pamamagitan ng pagiging bida. B. Bawal walang mask. I. Isanitize ang mga kamay at iwas hawak sa mga bagay. D. Dumistansya ng hindi bababa sa 1 metro. At A. Alamin ang tamang impormasyon. Lahat tayo ay may responsibilidad sa isa't isa na bawasan ang risk nating makuha ang virus. Ang pagsunod sa ating minimum health standard ay isa ring paraan para sabihing nirerespeto kita at gusto ko pareho tayong ligtas. Ang mas agarang pagsasabuhay ng B, I, D, A ay makakatulong sa mas mabilis nating pagbalik sa malusog na bayan. Muli, ako po si Dr. Beverly Ho. Lagi po nating tandaan, sa panahon ng pandemya, bida ang may alam.
Patuloy pa rin ang laban natin sa COVID-19. And together, we can beat the solution.
B. Bawal walang mask.
I. Isanitize sa mga kamay. Iwas hawak sa mga bagay.
D. Dumistansya ng 1 metro.
A. Alamin ang totoong impormasyon tungkol sa COVID-19.
Protektahan natin ang sarili at mga mahal sa buhay.
BIDA, be the solution sa COVID-19.
And we're back. Again, this is the 4th session of the National Health Research Forum for Action, titled Optimizing Financial Resources for UHC in Times of Pandemic. Now, let us proceed to the presentation of relevant studies. Each presentation will be allotted 20 minutes, after which 10 minutes will be given to our reactors to raise a few questions, and another 10 minutes will be allotted for the question and answer portion, where we entertain questions from our participants that will be collected from the chat box. All right, so for the first study, we will be joined by Dr. Maria Socorro Santos. Dr. Santos is currently the medical officer in the Department of Health, and she has been a health policy associate from 2013 to 2016. Today, Dr. Santos will present to us a preliminary result of the first round of implementation of the National Health Expenditure Survey. So let's all welcome Dr. Santos. Good morning and welcome to the webinar.
Thank you, Sir Jaker. Good morning, everyone. So today I'll be Health Expenditure Survey, or the NHES. The NHES is conducted by the Department of Health with technical assistance from USAID through the Health Policy Plus project. The UP Econ Foundation and the European Union also supported the DOH in the development of the NHES. So I'll be covering the survey design and methodology, and discuss results in terms of the sample characteristics, healthcare utilization, and healthcare expenditures. The NHES is designed to fill an evidence gap in health service utilization and the associated health expenditures. It includes detailed financing data where expenditures are disaggregated by component to include professional fees, lab and diagnostics, drugs and medical supplies, and room and board. It also includes financing sources for the specific expenditures that are identified: out-of-pocket expenditures or OOP, Philhealth, private insurance like HMOs, other insurance or transfers, and donations from charities or local government units. The NHES was designed based on the U.S. Medical Expenditure Panel Survey, with a household component and a linked medical provider component. The household component gathers household and individual level data on health service utilization, including visits to medical providers and places, details of event type, health conditions, and the details of charges and payment sources for each of the health events mentioned. The medical provider component allows for data to be validated and gather further details of services provided, diagnosis, and charges. The medical provider component is linked such that enumerators follow up to collect information from the facilities or providers that household member respondents mention having sought care from. In total, the household component sample is 503 barangays and 12,575 households, but some barangays were deemed unsafe for survey activities after sampling. The NHES was designed to capture most common conditions, including newborn packages, facility-based delivery, pneumonia, acute gastroenteritis, dengue, hypertension, and kidney problems, but not other specific diseases. The survey is sampled at the household level. The sample design follows the Philippine Statistical Authority guidance in the 2013 PSA Master Sample Design. The NHES household component employs a nationally representative multi-stage sampling design based on proportional provincial stratification with probability proportional to size selection of primary sampling units, which are barangays, in the first stage, and systematic sampling of dwelling units in the second stage. Barangays expected to be inaccessible due to hazardous travel or security concerns were excluded from the sample frame. The sampling methodology also accounts for anticipated non-response and attrition between panel rounds of data collection. So this shows the design and structure of the NHES. In the household component, the interviewer first collects information on the household composition, which generates a roster of the household members with names, age, sex, education, and employment. Next, we document health events and facilities that were visited by household members. We also collect details of health insurance, health status, primary care, risky behavior, patient satisfaction, and household expenditures. For each health event identified, NHES collects details of reason for care, billed or charge payments, and sources of payments. With household response about where care was availed, the MPC or medical provider component master list is developed. We separate MPC into three subcomponents: facility visits for outpatient, emergency room, inpatient, and dental, price inquiries for eye clinic, labs, therapy, and alternative care, and pharmacy for medicines, supplies, and equipment. So now I will describe the characteristics of the sample. For round one, which was conducted in December 2018 to June 2019, um, this, this presents the demographics of the households. Unfortunately, in this presentation, I will not be covering the results of the medical provider component since it is still ongoing. So for educational status, the majority of the sample has less than secondary education. For employment, unemployed individuals make up a large part of the sample, but we note that 48% of respondents are under the age of 25 and 29% are between ages 10 to 25. That is, they are likely to be students or unemployed. Informal employment includes working for private households, self-employed, or employer or worker in a family-owned farm or business. 17% of households are beneficiaries of the 4Ps program or the Pantawid Pamilyang Pilipino program. And for monthly household expenditure, around half of the households have income less than 2,099 pesos per month. The quintiles were generated by summing all weekly expenditures and multiplying them by 4, uh, monthly expenditures, and biannual expenditures, which are divided by 6. Finding quintile cutoff points using survey weights, and rounding cutoff points to the nearest 1,000. For age and sex distribution, which are not shown in this slide, male and female is pretty evenly distributed, and majority of the population are under the age of 30. Sorry, I didn't see. So, um, for the knowledge of having health insurance coverage, overall, 75% of households have at least one household member with any kind of health plan. And among household heads, 63% have Philhealth, while 35% do not have any insurance. Yet, respondents also indicated that only 48% of household members had Philhealth. So, in terms of the knowledge of having health insurance coverage by other characteristics, among the different age groups, senior citizens or those over the age of 64 have highest PhilHealth coverage. We see that those under 5 have the smallest coverage, and this does not seem to reflect the coverage of the parents who are in the age group of 18 to 44. So this may suggest that respondents weren't really aware that their children are covered by PhilHealth, even if they are a PhilHealth member. So as expected, the knowledge of PhilHealth coverage is higher among 4Ps beneficiaries. So for health-seeking behavior, around 70% of the population rate their health status as good or fair, and only 25% of the population thought that their health status was excellent or very good. We find that most household members with any health condition reported seek care at health facilities, and only 11.7% did not seek care in the past 6 months. The top reasons for not seeking care among those who had a health condition in the past 6 months include the unavailability of transportation, could not get an appointment, or other commitments and long wait times. By care type, household members who utilized healthcare services in the last 6 months with at least one visit in any of these, on average, the utilization across any care type was 21.6%. 12.5% for outpatient, and 2.4% in inpatient. Compared to the National Demographic and Health Survey 2017, our results are higher. So in the NDHS, outpatient utilization was around 8% and inpatient was 4%. So the figure on the right shows the proportion of household members with health condition who sought care at a facility. The most prevalent being general medical exams or checkups, immunization, hypertension, acute respiratory infection, followed by antenatal care and flu. In terms of insurance status, household members with a health condition that utilized healthcare services in the last 6 months, 60 to 70% of them utilized any all care types or any care type. So this is true for both PhilHealth covered, uninsured, or covered by other insurance. Majority of visits were for outpatient services. In terms of the facilities visited, utilization of barangay health stations, rural health units, private clinics, and public hospitals were similar for the total population and for the uninsured. Most of those covered by private insurance visited a private hospital of a private clinic, while those covered by PhilHealth had the most visits to public hospitals compared to other facilities. On average, 55% of households say that they have a usual source of primary care. When stratified among those with insurance and without, we find that more members with PhilHealth or other insurance have a usual source of primary care compared to those who are not insured. The top reasons for not having a usual source of primary care are infrequent sickness, recently moving to an area, or the high cost of medical care. Now we move on to healthcare expenditures and sources. The average per person health expenditure by care type among the insured and uninsured. Uh, we see that the average per person expenditure is higher for those with Philhealth insurance, with an average of 2,360 pesos for all care types, 4,998 for ER visits, and 17,517 for inpatient admissions. In terms of their average per expenditures are higher among the elderly and those with greater total household expenditures, and generally higher among those with insurance than without. So for financial protection, the average out-of-pocket expenditure by care type per person in the last 6 months is higher as expected for inpatient care. But we see that those with PhilHealth have higher OOP. The slide shows the average out-of-pocket expenditure in the last 6 months across all care types. We note that OOP is higher among older household members, people with higher household expenditures, and non-4Ps beneficiaries. Here we can see that OOP and PhilHealth are used as the most predominant payment sources for outpatient and inpatient care. OOP is used as the only payment source for emergency care, alternative care, and dental care. Here we see that among the 10 most prevalent conditions, OOP is highest for those with diabetes and asthma. Catastrophic health expenditure is defined as the out-of-pocket health spending that exceeds a certain proportion of a household's expenditure, with the possible consequence that the household will suffer financial hardship and subsequent impoverishment. We use a 10% threshold to reflect the current thresholds used by Wagstaff et al. And to align with SDG 3.8.2 on financial protection. The incidence of catastrophic health expenditures at 10% threshold is relatively low at only 0.9%. Again, it is higher among the elderly and among those who are unemployed in the lowest household expenditure quintile. So, the implications of the results of the NHES on policy. First, in defining primary care benefits and healthcare provider networks, 55% of respondents have a usual source of care. Utilization is higher for outpatient compared to inpatient. Top conditions for which care sought included the general exams and checkups, hypertension, and acute upper respiratory infections. And visits are typically to public hospitals, barangay health stations, and private clinics. The drivers of health expenditures in OOP, uh, PhilHealth support value, coordination of benefits, and global budgets. The average expenditure across care types was 3,625 pesos, and the driving cost components include professional care, medicines, and diagnostics. And the top financing sources are out-of-pocket, PhilHealth, and local government assistance. For a third issue of PhilHealth membership, premium setting, and no balance billing, there is low knowledge of having PhilHealth coverage among our sample, and households reported low PhilHealth financing, but initial MPC medical provider component data review suggests household respondents are often not aware of PhilHealth payments to facilities, especially for inpatient care. In terms of the implications of our results, implications of COVID on the results of the NHES, the COVID pandemic has affected the way we access and deliver healthcare services. This survey was conducted a year before the pandemic, and we can expect changes in utilization due to the limited operations of health facilities, some of which have halted delivery of non-essential services or have limited the access of patients by requiring appointments. Patients may also have limited access to these facilities due to the community quarantine that controls their mobility outside their homes. Thus, government interventions need to prioritize the poor, who have less alternatives to access healthcare. COVID is a new cause of expenditures, and the magnitude of which is still not fully known. The utilization of health facilities and laboratories due to COVID may have a significant effect on the expenditure patterns of households in 2020 and beyond. However, there is also an increased support and reliance on the government for financing COVID expenditures. The budget allocated by the government for COVID through the Bayanihan 1 and 2 and our general budget and the packages of Philhealth for COVID may be able to offset these out-of-pocket expenditures. So that ends my presentation. Thank you for listening.
Yeah, thank you very much, Dr. Santos, for that concise presentation of the National Health Expenditure Survey. Now, to give his reaction, let me introduce briefly to you our reactor, Dr. Carlo Erwin Panelo. Dr. Panelo is currently an associate professor in the Department of Clinical Epidemiology in the University of the Philippines, Manila. He is also the chief of party of the USAID UP Econ Health Policy Development Program from 2013 to 2016 and the chief of party of the USAID Palladium Protect Health Project from 2019 up to the present. So let us all welcome Dr. Carlo Panelo. Dr. Carlo, good morning.
Yeah, good morning. Thank you very much. So this is just a brief reaction to the NHES, the National Health Expenditure Survey, and I'd like to commend the Department of Health and the team of Director Elgo and Dr. Santos for keeping up with possibly the most ambitious financing survey that the country has ever done. The design by itself, which brings together the household information and matching it with facility level information, has not been done. And the study will definitely enrich the knowledge base of our understanding of how healthcare is being paid for in this country when the results are finally out. As a disclaimer, though, I would have to declare that I was part of the team that assisted in the design and the preparation of the NHES dating back from my days in the Health Policy Development Program and towards the end of the European Union support to the Philippine health sector. And the project that I'm working with right now, USAID's Protect Health, is also implemented by Palladium, and HP Plus is a sister project. Let me start off by just running through some key insights that I've gathered from looking at the results. The sample that was presented by or reported by Dr. Santos appears to be composed mostly of the poor, unemployed, and less educated, when comparing it to the National Demographic and Health Survey. And in the analysis, this type of sample population, or this nuance in the sample population, will need to be factored in during analysis. And it would also be important to review the participation rate by area to see where nuances on the kind of respondents would be made more apparent. And I've also noted that the reported 75% coverage as reported by respondents is lower than official figures, which in 2019, I understand Philhealth is reporting 92% coverage after cleaning out the database of the listahanan of the SWD. But this is much higher than the 63% that was reported in the 2017 National Demographic and Health Survey. While also there was relatively low knowledge on NHIP, I noted that the 4Ps and the elderly are more aware of their coverage status. And we need to understand whether this is the effect of targeted information drives, which I understand in the 4Ps would come in the form of their family development sessions, or is this an indication of adverse selection, where sicker members of the population tend to seek insurance more than the healthier set. In terms of utilization, as Dr. Santos pointed out, the use rate of 22% is more than double that of the DHS levels. And particularly, self-medication was high. I would tend to say that the 9% that went to pharmacies would probably fall in this category. And this would need validation. Moreover, the use rates would also benefit from an additional analysis to weed out whether the conditions were essential versus non-essential, meaning were the conditions that merited or warranted the consult could have been managed at home versus requiring really professional help. What is interesting, though, is that the rate of the non-use is 3 times that of the United States. And aside from this needing to be validated, there is also need to differentiate between delay in seeking care versus non-use or total non-use at all of health services. As we know, delay in seeking care or even the non-use of health services have significant impacts on health outcomes eventually. And interestingly, transportation appears to be the most common reason for non-use, accounting for almost a third. And could this be due to cost of transportation or travel time or access itself to transportation services? The DHS reported an average travel time of around 37 minutes in accessing care in the Philippines. And lastly, in terms of utilization, it appears that insurance status does not seem to influence use of services, because we see that seeking care from, on average, and whether it's at the RHU level or at the ER level, people with or without insurance more or less have comparable use rates. And a subgroup analysis might be helpful to tell us if this behavior is really that uniform across the different populations or income quintiles, or there is an artifact there in the study findings. And lastly, on financing, out-of-pocket was reported to be very high and even higher than the National Health Accounts report of 48% for 2019. And this will need to be validated with the MPC module if indeed out-of-pocket was really at that level. And a subgroup analysis by respondent, by condition, and by provider, as what was started in the slide shown by Dr. Soki, will also be helpful for us to pinpoint where the high out-of-pocket payments are really happening. And one example that was cited is that largely outpatient care and emergency room care are not covered. And these flags benefit design concerns for Philhealth. We also noted that those with insurance tend to favor private and use of hospital care, which is expected. But what concerns me also is that Philhealth coverage tends to increase healthcare spending, out-of-pocket costs, and catastrophic costs. Offhand, one would think, is coverage the one driving the costs upward, and raises questions about how our benefits are currently designed and whether we are setting up the system such that Philhealth coverage, for example, would actually drive the use of more healthcare services, and hopefully not essentials, and hopefully not the non-essential ones. Many studies support this as well, that NCDs account for most of the out-of-pocket spending. But what is significant here from a policy viewpoint is that families are spending even for public health. And this flags gaps in enforcing financing accountabilities. Let me close by just showing a few slides about what we know so far of out-of-pocket costs in healthcare in the Philippines. So this is a multi-year graph showing trends from 1991 to 2018 in terms of healthcare expenditures by source. And you will note that out-of-pocket spending continues to be the dominant source. And while there was a 3% decline in out-of-pocket spending rates compared to 2018, the absolute amounts are really more or less the same. But what is the take home here really is that in terms of the proportion of out-of-pocket payments relative to total health expenditures, the situation hasn't really changed in nearly 30 years. While, of course, obviously the size of the healthcare market has essentially tripled. But what this tells us is that the structure of our healthcare financing system has essentially remained more or less the same. Although social insurance, as you will see here, would come out as the fastest rising source of healthcare financing in the country. And as shown by Dr. Soki earlier, an earlier analysis by Racelis in 2016 shows that out-of-pocket spending is higher in certain conditions, particularly NCDs. But even conditions that are considered public health priorities like maternal care and even immunization, for some reason still incur out-of-pocket costs. But more importantly in all this, we see that a huge chunk of the out-of-pocket spending is really spent by the richest quintile. And I remember Secretary Duque himself even saying, so what proportion of this out-of-pocket spending is really non-essential? And hopefully the NHS will be able to tell us that at some point. But what I actually would want you to consider here is that there is also a wide disparity in terms of healthcare consumption across income quintiles, where the two poorest quintiles essentially consume only about a fifth of healthcare services compared to the richest quintile. And it begs the question, so what is the decent level of healthcare spending that should be aimed for by Filipinos? And you will notice also that while the poor are largely supported by government sources of financing and essentially incur only relatively little out-of-pocket costs, but also in the context of really very little healthcare spending to begin with, is that the government subsidies are actually favoring the non-poor. And when you look at the size of the bands of government sources of financing, namely local, national, and social health insurance, the richer quintiles appear to actually even enjoy more of the government subsidies, which is, again, a matter of policy priorities for consideration. So I'll end my reaction there. And if you want a deeper discussion on the healthcare financing system of the Philippines, you may want to check out the work we did with some of my colleagues back in HPDP days, which has been now published by the UP Press. So thank you very much, and good morning again to all.
Yeah, thank you very much, Dr. Panelo. Now we will open the floor for some Q&A questions that was collated now from the questions raised by your online participants in the chat box. So may I request Dr. Santos and Dr. Panelo to turn on their videos or mic. So first of all, before we go into some of more specific questions regarding the design of the study, I would like us probably to answer what is as mentioned earlier. I think NHS is one of its kind in terms of the design, which actually already incorporates expenditure data from the hospital side. What do you think is the value of the NHS study compared with other existing health surveys, and how can this be maximized in terms of its use for planning, particularly for financing, and what are the plans in moving this particular survey forward? Probably Dr. Santos and Dr. Panelo be able to answer that.
Yeah, I'll defer to Dr. Santos first, Jaker, on the plans for use of the NS. Over.
Yeah. Okay, thank you. Tool for monitoring when the UHC law was being developed. Because our current sources for health data in terms of health status, health service utilization, and health expenditures are scattered through different surveys. So we have data on health service utilization from the Demographic and Health Survey. The Philippine National Health Accounts, the Family Income and Expenditure Survey provide us information on household expenditures and on health specifically to some extent. And the National Nutrition Survey also gives information on utilization and health outcomes. But we don't have a source of data that will link all of these. We want to look at households in terms of how they are able to first their health seeking behavior, their health status, and link it to how they seek healthcare services. And then we want to link that to the expenditures. So if the reforms of UHC have been implemented for a significant time and we see changes, we want to see it at the household level. So we want to see that households are getting more aware that they should take care of their health. They are becoming healthier. They seek healthcare as needed, and their expenditures are minimized due to our interventions like Philhealth and rationalization of healthcare spending. So over to Sir Carlo.
Yeah, thank you, Sophie. Just to add, the level of granularity as well that the NHS data would be able to produce cannot be found in any of the different survey instruments that Sophie mentioned. So the survey really brings in new sets of information and information that will be particularly useful for Philhealth in terms of benefit design. So taking, for example, the initial data that was presented by Dr. Santos, where out-of-pocket spending across different types of conditions can actually be determined. The nature of those out-of-pocket spending, the kind of components that constitute that high OOP, would be able to be determined through the NHS data as it brings together the household and the facility level information. This will allow Philhealth to actually not only determine how much to actually pay for a particular condition to limit catastrophic spending, but also to target the design on which specific elements of care could be the subject of Philhealth payments. Thank you.
Right. Thank you very much for answering that question. Let's move on to some of more specific questions raised by our participants. From the chat box, there is a question: why did you use averages or the means for summarizing expenditure data? Why not use medians instead?
Yes, but in our final report, we can present the medians also.
All right. All right. Another question from Jason Sotilia: is there an analysis whether there is a difference in expenditure between males and females? I don't know if this has been covered earlier by your question, but this was a question raised by one of our participants. Would you like to answer, doctors?
Yeah, so based on our
Santos, please.
preliminary results, in the general population, males have 18% health-seeking behavior, while for females it's 25%. More likely because of the childbirth and maybe they go to the facilities with their children. So women are more likely to go to a facility compared to males. For those with health conditions, 66% of males and 70% for females. So it is closer if they are sick or if they're feeling unwell. Over.
All right. Okay, and I think one last question from our participants coming from Miss Sabine Court. I'll just probably contextualize the question. She is asking how long can the government support the health care of the poor, and how is it with the Universal Healthcare Act, taking into context the discussion right now we have on the preliminary results of the NHS study. Well, earlier, Dr. Santos actually provided some key implications of the study in relation to COVID-19, and I think this is how we wanted to put this question into perspective. Dr.
So
Santos?
yeah, so in terms of the support of the government for the poor, I think this is a requirement for as government for us to support those who are not able to, because health is more of it requires equity, and we know that as a very important contributor to economic development, human capital development, we should continue investing on health. And a lot of our a lot of the poor Filipinos are actually uh, are in the cycle of poverty. So if we keep them unhealthy, they will remain poor for many generations to come. And so I think that is we will continue supporting healthcare for as long as we can. In terms of COVID, I think we have not expected how the magnitude of the expenses, and we still do not know how long this pandemic will last. And the expenditures of the poor due to COVID will also be continued to be supported by the government, as we can see from the continuous bills being submitted by the Congress and Senate, such as the Bayanihan 1 and 2. So I think our government is committed to supporting our population, even in through this pandemic.
All right. I think one related question to that, no, that was just sent to us right now is on the method of the survey. No, if there are areas that are difficult to cover under the survey, and this excludes many of these areas in the in his survey, will this not lead to further marginalization of the residents of these areas, and how will that affect the inclusivity of the policies that will be derived based on the survey?
So this is a survey, so we're not actually intending to sample the whole population like a census. So even if these marginalized areas have been excluded due to safety concerns, I think other regions that have similar difficulties can represent these barangays as well. From our current sample, we have already seen that majority of the population sampled by the NHES is in the lower monthly income bracket. So most of them are already poor. So if ever these are not captured because they are um, on there are areas that cannot be accessed by our survey team, I think the NHES is representative enough so that the data will show the disparities across the nation. Thank you po.
All right, so I think we don't have any more questions for your presentation, Doc Sosi, and for the reactor. So we'd like to thank Dr. Mayor Sortoro Santos and at the same time also Dr. Carlo Panelo for sharing your expertise with us today. Thank you very much.
Maraming salamat.
All right.
Sir Jaker, sorry. Could you kindly check your microphone, sir?
Sorry. Yeah, for the second study, I would like to briefly introduce Dr. Helton Lam. He's currently a research professor at the University of the Philippines, Manila. He's also the consortium director of the Metro Manila Health Research and Development Consortium from 2014 up to the present, and director of the Health Institute of Health Policy and Development Studies up to the present. Dr. Lam will be presenting the study entitled How Protected Are Fieldhealth Members and Beneficiary, the 2017 Fieldhealth Support Value Survey. Unfortunately, he cannot join us live, but he has provided us with a recording of this presentation. So may I request the technical team to play the said video. Thank you.
Greetings of peace and good health, ladies and gentlemen. Allow me to present our study entitled How Protected Are Philhealth Members and Beneficiaries, the 2017 Philhealth Support Value Survey. I was ably supported in this study by my research team, including Dr. Dane Anasio, Dr. Jim Lopez, Ms. Heidi Valverde, Ms. Dani Molina, Ms. Abigail Landicho, and Mr. Chris Quinton. Universal healthcare aims to increase healthcare coverage and reduce patients' out-of-pocket expenditures. For PhilHealth, this translates to increased support value. According to Ulep and De La Cruz in 2013, by analyzing the Family Income and Expenditure Survey from the year 2000 to 2012, PhilHealth support value remained relatively low, averaging around 40%. Then, according to Oberman, Jowett, and Kwon in 2018, PhilHealth support value hovered between 50% and 60% from 2012 to 2015. And then, according to Alcantara in 2017, the PhilHealth support value for the year 2015 was 33.8%. The general objective of this study was to measure the level of support value of PhilHealth reimbursement against the patient's total hospitalization cost. Specifically, there were 8 specific objectives, all of which had to do with describing the support value, the out-of-pocket expenditures, the overall healthcare expenditures, and the hospital availment rates. For this study, we used the same basic methodology as the Alcantara study as a start. And then we added a national household survey of randomly selected Philhealth patients. 3 different phases of analysis were thus conducted in this study. First was a comprehensive analysis of the 2017 Philhealth claims database, then an analysis of field data from hospitals and patients, and finally a combination of analysis from the 2017 claims database with patient and hospital data to come up with what we call the adjusted support value, or support values that consider out-of-pocket expenses of patients. Simply put, support value is the reimbursement from Philhealth divided by the sum of the gross bill minus financial support plus unrecorded out-of-pocket expenditures. We accessed Philhealth 2017 records to obtain the reimbursement records. We then accessed 1,742 randomly selected hospital records and Philhealth patients from the 2017 records so that we could get the gross bill and hospital-initiated financial supports. And we visited these patients in their homes to ascertain any unrecorded out-of-pocket expenditures. The computed unadjusted support value for 2017 was 65.89%, while the adjusted support value for 2017 was 52.99%. The adjusted value takes into account all discounts and supports and the out-of-pocket expenditures of patients from the household surveys that we conducted. The Philhealth 2017 records showed that there were 10,004,488 claims for that year. We removed claims that were either for hospitalizations discharged earlier than 2017, claims that were not for inpatient, claims with unknown region or illness, or claims with computed support value of less than 0% or greater than 100%. And thus, we ended up with 3,683,803 claims that we entered into analysis. In terms of regions, Region 9 had the highest adjusted support value for 2017 with 63.74%, while the National Capital Region had the lowest with 40.25%. It should be noted that because we were not allowed to travel to ARMM for the household survey due to the Maguindanao massacre at that time, the adjusted support value for ARMM was computed as a composite of national estimates. In terms of Philhealth membership type, the membership type with the highest adjusted support value was the indigent member at 61.99%, which we think is because of the no balance billing program that they enjoy. While the type with the lowest adjusted support value was the lifetime members with only 42%. In terms of patient type, whether dependent or member, dependents enjoyed higher adjusted support value at 56.72%, while members' adjusted support value was lower at 49.95%. In terms of hospital ownership, whether privately owned or government owned, private facilities provided the lower adjusted support value at 47.27% compared to government facilities at 61.93%. In terms of facility type, whether the facility is a level 1 hospital, level 2 hospital, level 3 hospital, a maternity care provider hospital, or an infirmary dispensary, the highest adjusted support value was provided by infirmaries at 60.44%, while the lowest adjusted support value was provided by level 2 hospitals. If we cross-tabulate the membership category in government facility, then the lowest adjusted support values were experienced by lifetime members who were admitted in level 3 government hospitals at 46.56%, while the highest adjusted support value were enjoyed by informal economy members who availed of services in government MCP providers at 71.98%. When we cross-tabulate the membership category with private facilities, the lowest adjusted support values were experienced by formal economy members who were admitted in level 3 private hospitals with an adjusted support value of 33.11%, while the highest adjusted support values were enjoyed by informal economy members who availed of services in private MCP providers at 71.97%. Out of the 3,683,803 claims in 2017 that we analyzed, only 80 enjoyed 100% adjusted support value, for a relative proportion of 0.002%. The highest proportion going to indigent members at 30%, and the lowest going to lifetime members at 1.25%. In terms of illness type, surgical procedures enjoyed higher adjusted support value at 55.45% compared to medical types at 51.17%. In terms of sex, women enjoyed the higher adjusted support value at 53.53%, compared to men at 52.16%. Of the 1,199 hospitals registered with the Department of Health, Health Facilities and Services Regulatory Bureau, we were able to obtain hospital statistics of 589 hospitals, 49.12%. From this sample of 589 hospitals, the computed availment rate, which we defined as the proportion of admitted patients who are Philhealth patients or beneficiaries. The average availment rate was computed to be 82.83% among the 589 sampled hospitals, with the highest being Region 12 at 93.75% and the lowest being the National Capital Region at 75.2%. Please note that ARMM was not included in the sampling. On average, for each Philhealth admission, the overall total out-of-pocket cost was approximately 8,139 pesos and 85 centavos per episode. The hospitalization part took up 40%, while the pre-hospitalization part which is 29%, and the post-hospitalization part, which was 31%, took up a combined 60% of this total average. Thus, when we think about hospitalization, we have to realize that the costs before admission and after discharge may actually be higher than the inpatient services. On average, the pre-hospitalization out-of-pocket expenditures was approximately 2,391 pesos and 13 centavos, with the highest proportion for imaging at 23%, followed by laboratory tests at 19% and professional fees at 18%, with the lowest for others at 12%, which included transportation, communications, and supplies. On average, for each patient hospitalization, out-of-pocket expenditures in excess of Philhealth case rate was approximately 3,274 pesos and 27 centavos, with the highest proportion for room charges at 20%, followed by professional fees at 16%, and others at 11%, which included transportation, communications, and supplies. Now, when we look at the post-hospitalization out-of-pocket expenditures, it came to approximately 2,474 pesos and 45 centavos, with the highest proportion for laboratory tests at 19%, followed by professional fees, drugs and medicines, and imaging, all at 18%, and the least for others at 10%, which included transportation, communications, supplies, and others. On average, essential hospitalization out-of-pocket expenses were 29% higher among dependent members than paying members, and 11% higher for government healthcare facilities, and highest in Level 1 hospitals as compared to the 4 other healthcare facility types. When average actual hospitalization billing costs as contained in the claims database of Philhealth for 2017, Level 3 hospitals have the highest amount of hospitalization costs at around 102,000 pesos, 571.78. From the data, we saw that surveyed households' average income came to 240,000 pesos per year, while the average actual total bill plus out-of-pocket expenses for 2017 came to 77,319 pesos and 26 centavos. Therefore, if we divide the total hospital bill by the total income, we get 32.21%, which we call the healthcare expenditure as a percentage of total income. By World Bank and WHO definitions, these expenses would qualify as catastrophic expenditures. Thankfully, Philhealth adjusted support value was 52.99%, which effectively brought the 32.21% down to 14.2%. For our conclusions, number 1, compared to the Alcantara study, the unadjusted Philhealth support value increased from 33.8% to 65.89% for the years 2015 to 2017. However, if we apply the adjusted factors to account for out-of-pocket expenditures, then the adjusted support value increased from 33.8% to 52.99% for the years 2015 to 2017. Number 3, On average, an indigent member who is admitted to a government maternity care facility in Region 9 will enjoy the highest adjusted support value, while a lifetime member who is admitted to a Level 3 private hospital in the National Capital Region will have the lowest adjusted support value. Number 4, only 80 people out of the 3,600,000 claims that we reviewed for 2017 enjoyed 100% adjusted support value in 2017, with a larger proportion going to indigent members and the least going to lifetime members. Number 5, from a value chain analysis that brings a patient back to normal, including pre-hospitalization, hospitalization, and post-discharge time periods, out-of-pocket expenditures account for 60% of total healthcare expenditures. Out-of-pocket expenditures is higher for dependents as opposed to members, for government facilities as opposed to private facilities, and for Level 3 facilities as opposed to Level 1 or Level 2 hospitals. Number 6, on the average, a single hospitalization for an average Filipino household can still be considered catastrophic, as it would cost approximately 32.21% of their annual household income. Fortunately, Philhealth reimbursements protect members and beneficiaries from catastrophic healthcare expenditures by effectively lowering healthcare expenditures to 14.2%. Conclusion number 7, approximately 80% of the sampled hospitals admitted patients availed of Philhealth benefits, with more in government hospitals, 85.45%, and in maternity care provider facilities, 87.46%. For our recommendation, we recommend that Philhealth should work to relay how benefit packages work to its members and beneficiaries, and not simply being reflected as reimbursements in the hospital bill. In fact, when we visited the Philhealth members in their houses, many of them had very basic questions with regards to the benefit packages. Number 2, Philhealth should strengthen the monitoring system to track transparency of billings, review compliance of hospitals to Philhealth procedures, and resolve member queries with regards to billings and hospital procedures. Number 3, there is a need to minimize errors in the database encoding. This may entail the need to harmonize training among hospitals and other healthcare facilities with Philhealth personnel to process claims. Number 4, the true value of computing for support value statistics is not only to comply with the Philhealth law, but also as a very useful benchmark. By learning internally how regions and hospitals are able to achieve higher support value, Philhealth can improve its overall governance and delivery system, most especially in managing the Philhealth accredited hospitals. Number 5, as the national social health insurance for the Philippines, Philhealth may consider increasing reimbursements to cover the value chain proposition of including out-of-pocket expenditures incurred during pre-hospitalization and post-hospital discharge, as well as during the inpatient visits of their patients. And lastly, Philhealth can also incentivize the local government units to provide logistical and other applicable support to hospitals and healthcare facilities so that there is lesser need for for healthcare facilities to pass on unreimbursed costs to patients. By doing so, the number of Philhealth patients and beneficiaries who would enjoy 100% adjusted support value may increase to more than 80. Thank you very much, and please stay safe and healthy during this COVID-19 pandemic.
Thank you very much for the presentation, Dr. Lam. Now to give his reaction, let me introduce Dr. Carlos Paredes. He has been the Value Access Policy and Government Affairs Head of the Novartis Healthcare Philippines and has been a consultant to multiple organizations such as Department of Health, PCHRD, the World Bank Philippines, Asian Development Bank, and Fieldhealth, to name a few. Let us call in Dr. Carlo Paredes to render his reaction to the second study. Dr. Carlo, good morning.
Hi, good morning. Thank you very much. And I think Dr. Lam and his team really presented really good insights about the current status of PhilHealth support value. And just some of probably key points. I think first, most notably is that it's good news, for example, that we saw that PhilHealth support value increased over the years, may it be the unadjusted or adjusted numbers as presented by Dr. Lam. And probably this is because of different national government initiatives to support patients. And this includes, for example, the transition from the fee-for-service to all-case rates, no balance billing implementation, especially in government hospitals, and also point-of-care enrollment in different government institutions. Because as you may remember, PhilHealth and DOH also implemented this to actually increase utilization rate among the poorest of the poor Filipinos. What's interesting also for me is the difference in support value per different enrollment or membership types. If you can also recall, PhilHealth has standard payment across different member categories. And for example, this means formal sector and informal sectors and others will receive the same amount of benefits for paying for their health services. But probably the reason why there are discrepancies or variances across different membership types is maybe because of preferences, although it's not really mentioned, but probably also good to explore that there are other factors that may be considered in utilization. For example, formal sector members, since these are the formally employed individuals, they may have complementary private health insurance. They may prefer private facilities more or use more services versus the other sectors. And technically, this will also result to differences in PhilHealth support value. Second one, I think, is also noting that, despite NBB and despite the promise of PhilHealth covering as much health expenditure as possible, we saw that for indigent members, support value was still at 61.99% rather. And probably, it would be interesting to also look at this in different contexts. For example, what are the drivers of OOP? And as mentioned by the presentation of Dr. Lam, other OOP sources are coming from pre and post hospitalization. And sometimes, we always hear, for example, that some patients in government hospitals will need to go out of the hospital to get their medicines and other services. And largely, of course, this will also contribute to the lessening of support. Look into that more further, as the years and months to come, alongside our universal health coverage. Another good thing that was pointed out is the MCP coverage. For the longest time, I think DOH and Philhealth was working on to remove financial barriers to enable more facility-based deliveries in different parts of the country. And looking at 71% support value really is an encouraging. It means, for example, that pregnant women now in the Philippines, we may opt to go to MCP facilities or lying-in facilities accredited by Philhealth, and they get enough support from the National Health Insurance Program. Another point I think that was also mentioned, and I just want to highlight, is that in the Philippines, of course, when you go to different government hospitals, there will be heterogeneity in terms of the hospital billing structures. This is important, of course, because when hospitals bill are presented to you and it differs across institution, definitely it will lead to either estimation of your support value or overestimation. For example, if the hospital billing is incomplete or it does not include in instance professional fees of the doctors during the point of admission. And I think one opportunity as well is for DOH and Philhealth to actually lead discussions on this. When we look at hospital billings across different government hospitals and private institutions, is there a huge discrepancy in what are the variables that needs to be stabilized for us to be able to really assess the true cost of hospitalizations in the country. Again, next, I think since we're looking at Philhealth, it's good that we're seeing support value, but I always want to put you back to the fact that in the Philippines, we're still a very much mixed financing system. For example, for patients getting services in private health facilities, some of the payment methods, aside from Philhealth, would be the private health insurance or HMOs, and of course OOP if they opt to choose higher level services or new technologies. And definitely in government facilities, aside from Philhealth, they also receive budgets from the national government, including local and other social assistance funds. Now, while we see, for example, 61% support value of Philhealth, it doesn't always mean that that the rest is already paid by the patient, because there are also other financing sources available within the hospital. But it would also be good to also assess what different financing structures are available in local and national health facilities, and how can that synergize in terms of the direction of Philhealth to really cover as much cost possible for the health services. And I think lastly, while we go to more benefits and deeper coverage for health services, I think there's also need to later on integrate quality with the services that Philhealth is paying for. For example, important OOP sources are services that are not available in hospitals, and I think in the current financing scheme, Philhealth is not looking at that because the payment is fixed per case rate. But I think there is a need to also push for quality services. For example, we have to make sure in the end that the services that are being paid by the government are complete, and there's no need for patients to really go out of the hospitals and pay out of pocket just to get the medicine or the services they need for their treatment. Okay, I think that's it from my end. Thank you, and if you have questions, of course, probably Dr. Lam will be here in the call, and I will also be happy to accommodate some.
Yeah, thank you very much, Dr. Paredes, for the response and some recommendations on the study moving forward. So we'd like to inform our participants, should you have any questions for the presentation of Dr. Lam, we would like to encourage you to send in your questions in the chat box, or you may directly email him The email of Dr. Lam will be provided to you by her secretariat, or it will be shown in the chat box probably. So, do we have any questions from the audience? Probably for Dr. Paredes to answer. Okay, I guess we have none. So once again, thank you very much, Dr. Carlo Paredes, and of course to Dr. Hilton Lam for the presentation of the support value survey. That was a 2017 support value survey, but we can already glean some important again, thank you very much. Sir Milani, Benefits Development of Fieldhealth, which is the office responsible for the development of the overall corporate benefit agenda and design of the provider payment mechanism of Fieldhealth. Now, in 2012, she led the team that pioneered the development and benefit design of catastrophic packages branded as the Z Benefits of Fieldhealth, and she is currently the primary technical lead for the transitioning of the case rates payment mechanism of Fieldhealth to diagnosis-related groupings and the global budget. So let us all welcome Dr. Mel Santillan, who will be presenting the benefit development process of the COVID-19 packages. Good morning, Dr. Mel.
Good morning.
Welcome to the webinar.
Yeah. Good morning, Sir Jaker. Thank you very much. Good morning to all our participants of the 18th National Health Research Forum for Action. We would like to thank the organizers for inviting Philhealth to share and provide information how the COVID-19 benefit packages were developed. Currently, the process in the development of Philhealth benefits is being reviewed in order for the process to be more robust, inclusive, and transparent. Next slide, please. Okay, shown on your screen is the outline of my topic on the development of the COVID-19 benefit packages. I will focus on the costing of the benefit packages. Next slide. Now, the legal basis for benefits development comes from Republic Act 11223, or the Universal Healthcare Act, which mandates PhilHealth to cover all Filipinos and develop comprehensive benefit packages. Specifically on Section 6, described the spectrum of care to be provided that covers preventive, curative, rehabilitative, and palliative services of medical, dental, and mental conditions, as well as from Republic Act 7875, as amended by Republic Act 9241 and Republic Act 10606. Next slide. Now, the COVID-19 benefit packages were developed in March 2020, when we had to work on certain assumptions based on the current knowledge at that time. Our objectives for the development of the COVID-19 packages were the following. One is to provide ample coverage for all PhilHealth members and Filipinos for essential health services needed to manage COVID-19. Second is for benefits coverage for the spectrum of care for COVID-19 based on a systematic and evidence-based process that includes appropriate costing. And thirdly, to uphold PhilHealth's mandate to provide financial risk protection such that it will protect our members, the members of the National Health Insurance Program who are afflicted with coronavirus disease from impoverishment. Next slide. In general, this is the current process of PhilHealth in developing benefit packages. This process is now being enhanced in accordance to the UHC requirements, such as prioritization and health technology assessment recommendations. The steps in the current process are the following. One, there is gathering of data and evidence appraisal, followed by development of the package prototype, followed by a risk assessment and actuarial cost estimation and analysis, and followed by a series of management approval and dissemination. But included also implementation, monitoring, and feedback, and policy review. And the cycle goes on and on. Next slide, please. So for data gathering and evidence appraisal, this includes all the technical staff work, such as critical appraisal of evidence, determination of the minimum or mandatory standards of care based on current available guidelines, costing, which includes a mix of both top-down and bottom-up approaches, development of performance and monitoring indicators, mapping of capable providers, series of stakeholder consultations, and validation. Next slide. From the output of all the technical work in the first step, we come up with the minimum or the mandatory bundle of services, or the package prototype. The package of benefits includes the design of the provider payment mechanism, which undergoes risk assessment, as well as further validation if needed. And the process of risk assessment is based on a set of guidelines of Philhealth and its identified risk universe. Now, the package and all the completed technical staff work will be submitted to the Office of the Actuary for budget impact analysis and actuarial cost estimation and projections. And then clearance from different policy offices in Philhealth is also sought. These offices are the corporate planning department and all the executive offices in Philhealth. A series of management approval of the proposed benefit package is also sought from management, which are the Execom and the Philhealth Board of Directors. Now, for information of our stakeholders who are listening right now, the technical recommendations are separate from the decisions of the management. So certain provisions of a policy that will be implemented may come purely as a matter of policy based on management decision. So it's not purely the technical recommendations that you see as a final policy of Philhealth. Next slide. Now, the rest of the steps are the publication and dissemination and the series of orientations of stakeholders. During the implementation, monitoring and feedback are crucial. And this has been emphasized a while ago by Dr. Paredes, whereby data from whatever feedback and monitoring we get are input to the policy review later on. Next. The cost estimates for the COVID-19 inpatient package covers pneumonia as the main clinical condition. This was in March 2020. However, there is increasing evidence that COVID-19 can manifest through many other clinical presentations. As we all know, the current guidelines for COVID-19 is continually evolving. Now, assumptions on the probabilities used in setting disease severity and the corresponding case management were based on available information at the time of the package development in March 2020. These assumptions will need to be validated periodically, which we are doing now, with the best available evidence and expert consensus when applicable. Now, the unit costs used in the estimation were mostly derived from a 2017 survey commissioned by Philhealth as part of costing the inpatient benefits for pneumonia. Additional and/or updated unit cost information were obtained in March 2020 through inquiries with key informants, facilities, and suppliers. Similarly, cost data will need periodic updating, which we are also doing right now, to reflect current market conditions. We'd just like to mention that the 2020-17 cost survey were updated by using an inflator. Next slide. Full economic cost was estimated to determine prospective expenditure incurred in the utilization of COVID-19 services. Subsidies were not netted out of prospective amounts to be spent for the use of COVID-19 and other services, and all relevant cost items such as professional fees, hospital facility services, diagnostics and lab tests, procedures, medicines, and supplies are accounted for. Indirect costs were also accounted for through the use of fees and charges as opposed to production costs. We actually use patient charges for this. Next. The identification of relevant cost items was on the basis of recognized gold standard of care for us to be adherent to what is currently the gold standard. And these include, but are not limited to, clinical practice guidelines or case management guidelines, which means that only the fees and charges associated with the services, procedures, and commodities identified in the gold standard or clinical practice guidelines were included in the calculation. And for allowance for cost recovery, so allowance for cost recovery on the basis of observable market fees and charges was included. This means making use of prices as manifest in fees and charges that can be observed from providers of COVID-19 services in the market, as opposed to cost estimates and projections that are based on imputations. Next slide. The applicable market fees and charges from actual providers in the market who operate at scale were used when available. This means obtaining the price data only from accredited providers of COVID-19 services, to the exclusion of providers who signify intent but are not necessarily or actually providing services at the time of costing. Now, in defining quality of care based on regulatory proxies, these were defined in terms of measures such as licensing, certification, and accreditation levels. This means limiting the applicable set of fees and charges to those associated with licensed or accredited providers and certified diagnostic labs. Next slide. Now, a protocol-driven micro-costing, or this bottom-up approach, was used for the costing of the COVID-19 benefit packages. As there were no standalone guidelines on or CPGs for the management and care of COVID-19 pneumonia in March 2020, the Philippine Society for Microbiology and Infectious Diseases Interim Management Guidelines was used as the main reference in defining the case management protocol, and was supplemented by existing guidelines on the management of pneumonia. Inputs for the outline protocol were then listed, categorized based on the main cost categories included in the inpatient management of COVID-19 cases. The costing framework is being validated with experts. So now that we are updating the standards, we also need to update the costing framework that we used in March 2020. Next slide. With the objective of full financial risk protection, all direct services such as accommodation cost, professional fees, drugs and medicines, diagnostic and laboratory tests, excluding the SARS-CoV testing, because there's a separate package for that, staff time and personal protective equipment were included in costing the inpatient benefit package for COVID-19. And the use of off-label drugs were included in March 2020, but with the caveat that these will later be subjected to the positive recommendation from the Health Technology Assessment Council. To estimate the per-patient costs of COVID-19 inpatient care, prices from a variety of sources were compiled. These include market information from a National Facility Input Price Survey conducted as part of the 2017 Philhealth Pneumonia Costing Study, and supplemented by a canvas of market prices from different providers and suppliers for cost items not included in the 2017 survey. The applicable fees and charges were determined using lower and average and median values. Next slide for the benefit design. Now, the inpatient package for COVID-19 adopted the case-based payment mechanism. So case-based meaning it's a bundled payment. It is a bundled payment rate based on the case typing severity with a no co-payment requirement for the minimum standards or the direct healthcare services. Apart from shortening the turnaround time in claims processing using a case-based provider payment mechanism, the use of case-based payments with a no co-pay provision was envisioned in March 2020 to promote risk sharing between Philhealth and the healthcare provider. This is because savings from total charges that are lower than the package amount can be used to subsidize charges incurred above the package amount. And the no co-payment provision in that policy also aimed to ensure that the minimum standard of care is provided with allocative efficiency and at the same time contain cost, as facilities are prevented from overcharging patients and or adding services. Moreover, including this provision ensures financial risk protection and equity for members of the National Health Insurance Program afflicted with the coronavirus disease. Next slide. The main cost drivers in the care of COVID-19 patients appear to be the following diagnostics due to the numerous and repeated lab tests needed for monitoring the progression of the patient's condition, supplies from heavy use of PPEs, and medicines with the use of expensive off-label experimental drugs. In the case of severe to critical cases, the use of equipment such as mechanical ventilators and other interventions significantly increase also the cost of care. Next slide. For monitoring of the benefit packages for COVID-19, the monitoring is in accordance with the current framework for monitoring of Philhealth. That is the Healthcare Provider Assessment System. These are rules and guidelines of Philhealth used to monitor provider performance. And performance indicators to monitor provider compliance to the policy and standards of care are established in collaboration with the regional offices and relevant stakeholders. Random post audits are also conducted during the entire implementation of policy. So this is in general, and this is currently being applied for the implementation of the COVID benefits. Next slide. So as updates on the ongoing review and cost estimation of the COVID-19 benefit packages, as I present to you now, there is an ongoing review of the policy. Discussions, consultations, and validation are being undertaken by the technical team of the Benefits Development and Research Department. And this covers updating of standards with recommendations from the Health Technology Assessment Council, recosting of the bundled services based on the updated standards with validation from the experts, provisions on the cost-sharing scheme, such as co-pay and co-insurance, and other business rules pertinent to claims requirements, and as well as monitoring, developing the performance indicators. And the timeline for this review of the policy is during the entire fourth quarter of 2020. Again, we emphasize the previous statement that the final benefit package that will be implemented will already include decisions of the management and the board. Next slide. Now, pending Health Technology Assessment Council recommendation, investigational drugs, convalescent plasma, high-flow nasal cannula, use of CRRT, hemoperfusion will be included, but we need the positive recommendation of the HTAC. And there will be update, revised package amounts, pending recosting and actuarial simulation and projections. There will be delineation of differences in case type severity, inclusion criteria for each case type as to moderate, severe, and critical COVID-19. There will be updated reimbursement rules, specifically on claims filing, requirements from healthcare providers, and better information on entitlement of benefits, specifically cost-sharing rules. Next slide. Okay, this is my final slide and a message to all participants. Just because it is stormy now does not mean that we are not headed for the sunshine. Magandang buhay po at magandang tanghali po sa inyong lahat.
Much, Dr. Mel, for that quite comprehensive discussion of the prioritization process in the development of the COVID-19 benefit packages. Now we open the floor for the reaction of our reaction of the third study. To briefly introduce our reactor, Dr. Alvin Caballes is a professor at the UP College of Medicine. Concurrently, he is the head of the UP College of Medicine Social Medicine Unit. He is also the head of the Philippine Children's Medical Center Division of Pediatric Surgery. Furthermore, Dr. Caballes also holds a master's degree in development economics and a master's degree in public policy. Let us all welcome Dr. Alvin Caballes. Dr. Alvin, over to you.
Good day, everyone. I have been tasked to provide a reaction to the commendable presentation of Dr. Mel Santillan on how the Philhealth had developed its COVID-19 benefit packages. I have worn many hats over the years, including consultancy engagements with Philhealth. I have therefore had the opportunity to work with Dr. Santillan on several occasions. I hold her and her staff in high esteem, knowing what they have been trying to accomplish given the continuing challenges at Philhealth. My reaction will center on the following areas. I would like to beg Dr. Santillan's, Philhealth's, and the conference participants' indulgence as I tackle these. I am admittedly an outsider to the benefits development process. My perspective is mainly that of a common observer, a Miron if you will, and the succeeding talk will raise more questions than it answers. By way of providing context to the current pandemic circumstances, I would like to compare these with what transpired previously with SARS. There are striking similarities in the spread of the disease and subsequent Philhealth response. While we did not know it then, SARS proved not to be as easily contagious as COVID-19 and did not spread across the Philippines to the same extent. There were a handful of deaths, which, while unfortunate, pale to what we have at present. The Philhealth response is summarized here. For COVID-19, this was more forthcoming in that Philhealth guaranteed the payment of all hospital charges early on. The eventual case rate values were, at least for the more severe COVID-19 cases, more substantial than what was offered for SARS. Philhealth nonetheless took the same amount of time to come up with a corresponding package, considering that the present pandemic has spread more rapidly and pervasively. We now know that most East Asian countries, which had suffered more from SARS, had ramped up their readiness for the next big one. They therefore responded more swiftly and effectively. We did not learn the same lessons, with the apparent delay in Philhealth benefits development being one such bellwether. Dr. Santillan had related how Philhealth goes about defining benefit packages. The processes are, of course, meant to provide adequate financial support to what are truly appropriate, effective, and quality interventions. Both clinical and financial information are critical, and stakeholder consultations are needed to validate the drafted benefits. Ultimately, case rates or the corresponding Philhealth payment rates are set for the specified conditions. The process, while comprehensive, can also be tedious and prolonged. I am not aware of the average time it takes for Philhealth to come up with a benefit package. Nonetheless, the lapse time may be considered worthwhile and the entire process necessary so as to come up with optimal rates for, say, chronic conditions. However, is the same process appropriate for more urgent circumstances? To provide an analogy, please allow me to wear my surgeon's hat temporarily. We make the distinction between elective and emergency cases. We have all the time to double check everything and even forego elective procedures. But this is not the case for emergencies. In fact, for the most urgent or stat cases, we proceed and work with what little we know and act fast, if not furiously. Of course, there are systems in place to enable these stat operations, such as ORs and staff on standby for these contingencies. So the question then is whether Philhealth has such a stat system in place. To some extent, the initial fee for service arrangements provided the emergency remedy, but this was just a first aid measure and was not a definitive response. Just like a tourniquet applied to a bleeding limb, these bought time and possibly political space, but could have also caused further damage. Nobody was sure about what constituted the right therapeutic regimens at the outset. But Philhealth's commitment to pay even exorbitant charges also sent a signal that providers did not be mindful of cost or resource limitations. The needed but troublesome tourniquet could have been removed earlier if the arrangements for the more definitive interventions were in place. The inpatient COVID-19 case rates were eventually released for packages premised on pneumonia of varying degrees,
Ladies and gentlemen, we apologize for the interruption. We're having some technical issues. May we kindly ask Sir Jaker, if we can proceed to the Q&A muna, and then we'll just fix Dr. Cabalis's video and we will play it after na lang po ng Q&A. Thank you.
All right, so apologies for some technical problems that we are experiencing right now. So let's move on to, may I call in Dr. Mel Santillan to join us once again for the Q&A segment.
Yes, Sir Jaker, I am here.
All right. So first of all, we would like to raise some very key important questions. While we are here talking about development process of COVID benefit packages, the different COVID with the usual benefit process for other regular benefit packages, and is there any significant difference in changes, and if ever, what are those, and what's the rationale behind it?
Yes. For the usual benefit package development, the guidelines that we use are pretty much stable in the sense that they are not evolving, unlike for the COVID-19 benefit. As I've particularly emphasized that the policy was developed in March, and a lot of things have already happened since March, especially on the current guidelines. We've had updates already, and we have updates, especially for the drugs and investigational drugs and interventions. So that is one very important difference. Another is the costing. For most of the benefit, special catastrophic benefit packages of PhilHealth, we use the same approach of micro costing, which is a bottom-up approach. But for this one, although we did use a bottom-up approach, we had to consider the patient perspective. So we did a full economic costing and using the perspective of the patient. For the usual benefit packages of PhilHealth, we rely heavily on reference prices and what is standard. So that's another difference between the usual benefit process development with this COVID-19 benefits development. And then thirdly, for the usual benefits of PhilHealth, we really take time to involve a lot of stakeholders. So for catastrophic benefits and the usual special benefits, we conduct a lot of series of stakeholder consultations. But for the COVID-19 in March, we had very limited time. We had actually 2 weeks only to develop those benefit packages covering testing, inpatient, and 2 versions of the inpatient and the community isolation. So we had 2 weeks to develop that and a few hours to present to management so that we can follow the marching order of the government to provide benefits for COVID-19, especially for testing and inpatients. So I guess those are the very obvious differences between the previous, the usual process and what went into the COVID-19 developments.
Right. Thank you very much, Dr. Mel, for going into the details of answering that question. No? And I think it was well appreciated by many. No, most of by all of the Fieldhealth members. I think that Fieldhealth was able to rapidly develop a package for a disease that is much of the information is not really known to us. And we have a question here now coming from our audience, Miss Annabel Ribulido. She said that well, it is reassuring to hear about the COVID benefit packages being developed, but all other illnesses have also been affected by the pandemic. No, it affects or impacts the treatment methodologies and the outcomes. For example, management of non-COVID cases have been moved to out. And they are delayed are in the hospital. So I think the question would be, while many of the regular benefits are not well, is there a ongoing process in improving the regular benefits, given that there are other considerations in terms of the cost that are being incurred right now in delivering these regular benefits to our members?
Yes, Sir Jaker. I did not hear all of the questions, but I will answer based on what I heard from you. In general, the benefits, all the benefits of PhilHealth are being reviewed. This will be considered in the development of the benefit development and planning protocol of PhilHealth. This will come out later. But we cannot continue reviewing piecemeal, like for every condition. We have to do everything for each and every condition, and that is very inefficient. As I've said, the PhilHealth, in accordance to the Universal Healthcare Provision, in Chapter 4, Section 18B, that PhilHealth will transition to a provider payment mechanism that will be prospective based on DRGs and global budget. So that will affect later on the claims processing. It will be a reporting sort of in claims, and there will be no individual claim submission. That's why turnaround time is being affected. No, the capacity of our regional offices is not optimum, and they have to hire warm bodies to do the claims processing and evaluation. So moving forward, the vision is really to automate and to transition to a more responsive payment mechanism, as well as more comprehensive benefits that are in accordance to a development planning protocol that will be more transparent, that will include prioritization and health technology assessment. So I guess I've answered most of the questions I heard. I'm sorry, I did not hear the question of the
Right.
question. Thank you.
Yeah, well, that's okay. I think you have covered the questions, the question that was being asked. I know there, Dr. Caballos is with us right now, and I would like to ask him to join us in this Q&A. While we haven't really been able to capture the entire response earlier, that was presented through a video. But I would like also to ask Dr. Caballos of his insights. No, early on during the presentation, you mentioned that there are, you seem to provide some difference in terms of how Philhealth was responding in the early SARS pandemic, SARS disease, no, and right now with COVID-19, and there are some really glaring insights that you have pointed out there. Dr. Caballos, would you like to elaborate on that, and how would this actually impact on
So essentially, Philhealth,
of the field
are
is
you
moving
able to hear
forward?
me? I'm sorry, are you able to hear me, Jake? Hello?
Go
Yes,
ahead,
Dr.
Dr.
Caballos,
Caballos.
we can hear you now.
Well, okay. So what I was pointing out earlier was essentially it took the same, almost the same period of time before a package was released. Knowing that we have a worse pandemic in our hands right now. So I mean, is it going to be this way always? That for the next pandemic, it will take another 3 months before we come out with a. I mean, Philhealth comes out with a package. It probably should not be that way. Now, unfortunately, the rest of the video did not play out, but I also pointed out comparisons in the values for SARS and, well, the present COVID-19, and compared that with a gold standard, which is ARDS. And I pointed out that essentially we are dealing with ARDS. And yet the variation in case rates is very, very large. Okay. The case rates for well, critical pneumonia, critical COVID-19 pneumonia is more than 2,000% higher than that for ARDS. So which begs the question, is the package too high, or are we underpaying ARDS all the while? So, and if we are underpaying ARDS, then are we also underpaying all the rest? So either way, I guess that has to be looked into. And as I said, I don't know the math behind the development of the case rates, especially for COVID-19, but hopefully the math can be shown. Why is this more than 2,000% higher than what Philhealth pays for ARDS? Understandably, there are additional costs which aren't present with ARDS. But again, where is the math for that? So those are some of the things that I did mention, and I don't know if the rest of the video will be shown.
Yes, sir. We are just waiting for Sir Jaker po na disconnect lang. But let's okay. All right. So let me just take over po, Doc, from Sir Jaker. We're just checking. Okay. I think he is having connection problems right now. So at this point po, we will play the right version of Dr. Caballes' video.
Skip the earlier parts and just go to where we left off.
Yes, sir. Thank you.
I'll sign out for a while.
Thank you, sir.
Good day, everyone. I've been aware of the average time it takes for Philhealth to come up with a benefit package. Nonetheless, the lapse time may be considered worthwhile and the entire process necessary so as to come up with optimal rates for, say, chronic conditions. However, is the same process appropriate for more urgent circumstances? To provide an analogy, please allow me to wear my surgeon's hat temporarily. We make the distinction between elective and emergency cases. We have all the time to double check everything and even forego elective procedures. But this is not the case for emergencies. In fact, for the most urgent or stat cases, we proceed and work with what little we know and act fast, if not furiously. Of course, there are systems in place to enable these stat operations, such as ORs and staff on standby for these contingencies. So the question then is whether Philhealth has such a stat system in place. To some extent, the initial fee-for-service arrangements provided the emergency remedy, but this was just a first aid measure, like a tourniquet applied to a bleeding limb. This bought time and possibly political breathing space, but could have also caused further damage. Nobody was sure about what constituted the right therapeutic regimens at the outset, but Philhealth's commitment to pay even exorbitant charges also sent a signal that providers should not be mindful of cost or resource limitations. The needed but troublesome tourniquet could have been removed earlier if the arrangements for the more definitive interventions were in place. The inpatient COVID-19 case rates were eventually released. For packages premised on pneumonia of varying degrees and risks, it may be worthwhile to compare these with related existing case rates. Non-COVID-19 pneumonias are currently differentiated by Philhealth in terms of risks, often by their etiologic agents. There is a 100% difference between moderate and high risks. ARDS has the same rates as the latter. With ARDS or ARDS as the reference, SARS rates were higher by 50 to 200%, and COVID-19 case rates can exceed 2,000% of this value. I am not a pulmonologist, an infectious disease expert, nor an intensivist. I could surmise, though, that ARDS and SARS in ARDS and COVID-19 in ARDS will have the same essential resource requirements: critical care, ventilator support, antibiotics, fluids, and nutrition. Given the highly infectious nature of COVID-19, there are additional structural requirements which add to fixed costs, and consumables such as PPEs, which are variable costs. Anti-inflammatory and possibly antiviral drugs are additional expenses. But I would like to see the math that shows that the latter are enough to account for the rate differentials. Of course, it may also be that the reverse would be more valid, that COVID-19 rates are more realistic and ARDS and related conditions are undervalued with the given case rates. Differences may also be attributed to the COVID-19 packages being apparently based on charges rather than costs, but the same paradigm used for other conditions, including those belonging to Z benefits. The benefits development rightly incorporates monitoring. The inpatient packages in particular specify that hospitals should not have any other outstanding charges for patients. I am not sure to what extent this is implemented or how Philhealth monitors compliance, but I know that this is not uniformly complied with. Here is a preliminary bill for a COVID-19 patient in a Level 2 hospital in Region 4A. There are questionable items such as a small OR fee when no operation was done, and surprising amounts such as oxygen use being one of the leading expenses. The final bill includes professional fees, and after deducting the senior citizen discount and PhilHealth case rate, this amounts to 500,000 pesos. While the case was labeled as severe pneumonia, the total payments that the hospital and attending physicians will end up receiving from out-of-pocket and PhilHealth reimbursements approximates that for critical pneumonia. It would seem, therefore, that the PhilHealth case rates had an additional value, that of a price index for providers. If this happens in one case, in one hospital, how many more cases and in how many more hospitals is balance billing, if not price manipulation, for COVID-19 also occurring? The current benefits development mechanism of PhilHealth is geared towards selecting which conditions are to be supported and, through the eventual case rates, to what extent. This is a necessary process given the current provider payment system of the corporation. Nonetheless, the process and payment system appears not to lend themselves well for acute, complex, and widespread conditions such as the current COVID-19 situation. As mentioned by Dr. Santillan, the current inpatient packages were developed only for pneumonia cases, where severe COVID-19 is a multisystemic illness. It took 3 months for the inpatient COVID-19 packages to be developed. It has now been more than 6 months since these were released. Have these been reviewed? Are revised or new packages to be released soon? What has been the impact of the packages or case rates on the delivery of services? And if PhilHealth is to get a step ahead in its COVID-19 support, is it now working at developing vaccination packages? Everything is a work in progress. PhilHealth is no exception to this. We hope the lessons come in time to better address the COVID-19 situation and certainly to make PhilHealth more able to anticipate and respond to the next health crisis that is sure to come. Thank you all.
Yeah, thank you very much for that feedback and reaction that we have earlier discussed with Dr. Caballas. And let's proceed. Let's move on again to our. Let's go back again to our question and answer. I have one question in for both Doc Mel and Dr. Caballas. Earlier, Dr. Caballas mentioned the need for us to put into place, no, and even PhilHealth has actually had in place a monitoring, no. But the question would be how intensive or extensive this monitoring has been undertaken by PhilHealth in terms of looking at the utilization and of COVID benefit packages, and as also a means to as a feedback mechanism in terms of improving the benefit packages. As mentioned, there are a lot of variations, no, in terms of the costing of COVID across different facility types. So how do you look at these different information coming from the provider, and how does this feed into the ongoing review of the benefits packages?
May I respond to that?
Yes, Doctor.
Because the video was cut. And I would have presented an example of a patient who got a bill of 1,000,000 pesos. And well, there were deductions for senior citizen and the Philhealth case rate. And what's I would say suspicious about, well, first of all, the family was made to pay over and above the Philhealth case rate, which is well against the COVID-19 package, supposedly. Okay, so that happens. Okay, it happened in a hospital for a patient, and I guess it happens to many other patients in many other hospitals. Secondly, if you look at the figures, and you net out the case rate and you net out the senior citizen discount, what do you get? You get a total out of pocket. I mean, case rate plus out of pocket. If you add them together, you get something which is really almost equal to what PhilHealth will pay out for critical pneumonia. So again, I also mentioned that in a sense, the case rates are also being used as price indices. And I guess this ties up with one of the comments mentioned earlier, that why is it that PhilHealth support seems to lead to inflation of out-of-pocket expenses? And I guess this is one of it. This is one instance wherein, well, PhilHealth says this is the price and everybody follows the price. And again, the question now is really for PhilHealth. To what extent are these cases being monitored, and what is being done? And I also pointed out in the rest of the video that well, the PhilHealth keeps on saying that something new will be coming out, but it's been 6 months. It's been 6 months since the COVID case rates came out. 6 months is really a very long time for a new package to be developed. So hopefully that comes out really soon. Thank you.
Yeah, thank you very much, Dr. Caballos. Doc Mel Santelian, are you still in the room?
Yes.
Yeah, would you like to respond to that?
Yes, I would like to respond as a technical person in PhilHealth. During the past 6 months, a lot of things have happened. Admittedly, that is a room for improvement for the corporation to strengthen its monitoring and its enforcement rules. But anyway, for the past 6 months, many things have changed in the corporation. The focus was more on the requirements for the legislation and what transpired. So although work from the technical side is happening, there is now a disconnect between the technical and the management. So the focus was not on the changes to fast track the needed changes, as I've said, to adhere to what is current in the guidelines and the guidance that are being issued, and also the rules on claims and monitoring. So that is something that has to be decided upon by our current management. And although we say this will come out, it really has a lot of bearing on the political environment that we are working on. So I can only speak on my behalf. I cannot say for sure right now. There's a lot of uncertainty that is happening. So it will be up to management on how this will be addressed later on. Over.
Okay. Well, thank you so much. No, we don't have really much time. The discussion has really been interesting. How much we wanted to continue with the discussion. Unfortunately, we have very short, limited time to move forward. It's already over 12 o'clock. And but thank you so much, Dr. Mel Santelian and Dr. Alvin Caballos, for those insightful information that you have provided and insights regarding benefits development in times of COVID-19. And for all of our participants who have additional questions to Dr. Mel or to Dr. Caballes, we would highly encourage you to continue sending your questions, specific questions. We will ferry them to both of our speakers in the reactor this morning. So thank you. And for the last part of our session this morning, I'll be providing a quick synthesis of what has transpired and what we have actually learned and some key takeaways for this morning's session on optimizing financial resources in times of the pandemic. Let me go back to what Director Mamaril earlier presented in her discussion. Let's go back to the intent of the law, and the law says that the goal of UHC is to really provide access to the entire population, to all Filipinos, without them suffering from financial hardship. So this actually is a very strong anchor as we continue to discuss all of the reforms that we wanted to implement moving forward with the UHC. However, there are also some disruptions along the way, and we have COVID-19, and other than that, we have natural calamities also contributing to some delays in many aspects in the reforms that we are actually doing. But we got a very good an overview of the plans and the ways forward in terms of how the Philippines is intending to implement universal health care. In fact, in terms of the budget requirements and the support, we've seen that it is actually growing over the next few years. But also, at the same time, we are quite cognizant of the fact that the current situation, the current pandemic, has also put a strain in terms of the resources and may need for us to do a re-evaluation or reprioritization or rebalancing of the current priorities that we have right now for both Philhealth and DOH, and mainly for the entire health sector. But of course, importantly, as we integrate mechanisms for planning our ways forward as we go implement universal health care, there is a need for us also to look into existing evidences, generating evidences that would actually help us be able to craft a more robust plan. And as presented earlier, the National Health Expenditure Survey and the Support Value Survey are two important studies that were undertaken prior to the COVID-19 crisis. However, this has already provided us a good glimpse of the current health market landscape in the Philippines, healthcare landscape in the Philippines. And we are seeing that there is already low utilization, there is already a low knowledge, low financing in some respects. And with the COVID-19, we might anticipate that this number of these indicators has been adversely, all the more adversely affected. And but these evidences provide some more granular way for us to plan forward. And there is also a strong point being mentioned in our third study in the development process, that all of these different studies are necessary for us to be able to beef up our financing mechanism, particularly in terms of developing benefit packages, not only for COVID-19, but also recognizing that this type of crisis or wide-scale health hazards may be something of a norm, and this is something that we have to integrate into our current scenario setting, planning, and even monitoring, and even restructuring our governance arrangements within the health sector, and even our delivery systems will be affected. So overall, we had a very good and insightful discussion for session 4, and we hope that everyone also are enjoying the the presentations as well as the exchange of ideas among the presenter and the reactors. So just a few reminders before we end. No, if you have encountered problems during the webinar, lost communication connection, or did not finish the webinar, links to the webinar will be replayed, will be sent to you to your registered email address. To receive the certificate of completion for this webinar, please take the quiz and answer the evaluation by the link, which will be sent to you through your registered email address the day after this session. That would be tomorrow. So participants are only allowed to take the quiz once. You need to score 80% or higher to receive a certificate of completion. Otherwise, you will receive only a certificate of attendance. Now, if you wish to receive a certificate of attendance, just go to the link that will be provided to you via email. The webinar quiz will only be available for the next 48 hours. So after it has been sent to you, so please take the time to answer the quiz. After that, it will be closed and your certificate will be issued at a later date after verification of the scores. As a final reminder, please double check your email address during the registration. Incorrect email addresses will not receive related announcements. All right, for the upcoming webinar sessions of the National Health Research Forum for Action 2020, our fifth and last session would be on the 15th, on the 18th. Sorry. On the 19th of November, that will be tomorrow from 9 a.m. to 12 noon, which is entitled COVID-19 Lessons in Ways Forward. That will be November 27. I'm sorry, November 27, 2020, 9 to 11 a.m. COVID-19 Lessons and Ways Forward. To register, please visit the link that is provided on the screen. And please be reminded that you need to register individually. So if you want to participate. So we hope to see you there. To ensure that you register properly for our webinars, here are some of the reminders on how to register. After filling the forms, please make sure to register to the webinar jam to gain access to the webinar link. To do this, just click the link provided for each session to register to the webinar jam. Once in the webinar jam, please click the register button seen at the bottom right corner of the page and fill out the form and click the register now button. Now you will be provided a link to the webinar, so please take note of this, and you will go to this link on the day of the webinar. After a few minutes, you will receive an email containing the webinar link and registration confirmation. You will also receive a notification via 24 hours before the webinar and 15 minutes before the webinar live to remind you that we're about to start. The organizing committee of the 18th National Health Research Forum for Action is currently applying for the CPD accreditation of the National Health Research Forum for Action sessions for medical and allied professionals. To fulfill the requirements, we are requesting for your PRC registration license details for submission to the PRC. So please visit the link being shown in the screen. So thank you very much for joining us today. For questions and comments about the webinars or to reach the organizers, please email us at NHRFA2020@gmail.com. For inquiries about the registrations and certificates, please email us at nhrfa.ituro@gmail.com. So this is Virgil Declaro from USAID Rich Health Project. We hope to see you tomorrow for the next session. Thank you very much, and God bless us all.